dentistry is fast changing. Now the technology, techniques which we used to learn or we used to practice a few years back now is being challenged. And now we are thinking beyond the conventional dentistry. So this is exactly my topic, the past, present and the future. And I will be discussing only one treatment modality. Now this kind of situation you must have encountered in your day-to-day practice, either in the dental college or in your private practice. These are the traumatic injuries and they very frequently occur. And if you see the prevalence, then you will find almost 1/3 of the children below the age of 5 years, they suffer some or the other kind of tooth trauma in their primary dentition. And the situation is not very good as far as the permanent dentition in children is concerned. Almost 1 in every 5 child, he also receives these kind of tooth trauma. If you further go back, then we will find that the most common age group for the tooth trauma is the 11th year. This is the period where the child is almost in 4th or 5th standard, and he tries to learn a number of activities. He is involved in sports activities, in learning by skill and all these things, and fighting also. And because of that, this particular age group is most prone for this tooth trauma. The shocking thing is that 30% of the total injuries which occur in the permanent dentition in children, they are in young permanent teeth, where the roots are not formed, the tooth is little comparatively weaker, and even sometimes it is not fully even erupted. Fall remains the most common cause, followed by sports and then the accidents. And the predisposing factors, one of the most important is the increased overjet, which is more than 5 millimeters. It makes prone. But in indirect, when there is a blow to the chin, the force gets transferred to the posterior condition, and sometimes it results in the fracture of the bones and TMJ as well. Ellis and Davy, they gave a classification which is, as far as pediatric dentistry is concerned, is the most accepted type of classification, and it talks about right from the enamel fracture till the complete en masse fracture and its replacement. But I want you to emphasize the class 4 type of fracture, where the tooth becomes non-vital, may or may not be fractured, but it becomes non-vital, discolored. Now, as I told, the 30% of the cases you find in young permanent teeth when the traumatic injuries occur, and roots have not completed. So when the patient presents to you with this kind of situation, he had trauma, he took some medicine, and then the problem was resolved. Now again reports back to you after say 6 months to 1 year, and he has a pain, swelling, sometimes sinus formation also, and when you take the radiograph you find this kind of situation. Now it seems little easier to control or to treat such conditions, but they are not as simple. Rather, the treatment of such teeth is a great challenge. And conventionally what we have been doing from 1968 till date, there are two approaches, non-surgical and surgical approaches. Non-surgical approaches, we all know, we all have read about the apexification. What we just do, we try to create years. We call the patient in 2 appointments. In first appointment, we just gain the excess, disinfect the canal, and then seal it. And then the second appointment, we just try to fill it with some good material, preferably the calcium hydroxide, and then we just wait for the evidence of apical plug formation or the bridge formation, what we call it as. Number of materials have been tried in the past, but the calcium hydroxide remains the material of choice for this because of its cost effectiveness or because of its availability and all. Now what we have done, we have just produced an apical plug and we have obturated the canal without bothering whether the tooth has gained enough strength or not, whether the tooth has gained some amount of vitality or not. So this kind of symptomatic treatment we have been doing. Now, more interestingly, these 4 types of closures are anticipated, the evidences show, The first is the normal root development, which hardly occurs when you try apexification. The second is the canal remains the same. Dentin thickness is not going to increase, but length gets increased, and you find some amount of cementum-like deposition, and then the closure occurs. But if you see, you will find the pulp remains, the blunderbuss canal is already visible. In third, neither the length nor the width of the root dentin increases, but you find some amount of apical plug which is formed at the radiographic apex. But the fourth one, in which nothing happens, neither root length increases nor the thickness increases, and the apical plug which is formed, it is cervical to the radiographic apex, not even at the radiographic apex. And unfortunately, this is the most common anticipated bridge formation which we anticipate. What I mean to say, that the treatment which we are providing, you just see what we are doing. We have provided an apical plug, further compromising the length of the root, and initially also the root length was inappropriate, even the thickness was not there, so tooth remained weak, but you see, we have provided some kind of platform on which we can obturate this tooth. Now if I talk about a couple of cases, the case report, now if you see and you will appreciate, tooth number 11 is the right central incisor. We tried apexification procedure, and you will be able to appreciate when we obturated, the apical plug which was formed was little cervical to the radiographic apex. The canals were huge, large canal, thin dentin, shorter root. The root is even shorter than the lateral incisor if you compare. Another case, similar finding. Right? I have chosen only two cases for you. But what I want to convey, that though we are providing the treatment, but we are not strengthening the tooth. Tooth is in the oral cavity, but it is something like hathi ka daant, elephant tusk. It will not be able to perform the treatment, and in such cases, you will find the cervical fractures are very, very common. So the prognosis of these kind of treatment is also questionable. So these are certain limitations. Long-term therapy means you have to wait for say 1.5 to 2 years for the complete bridge formation. You are not going to strengthen the teeth. Tooth will become very, very weak, and then thereafter also you need to obturate the canal, and then you have to give full coverage restoration. This is what we have been practicing. Now to reduce the time, another technique came in 2001, which is known as one-step apexification or apical barrier technique. Now in this also, instead of waiting for apical plug formation, we introduce some of the materials which will set immediately, and then we obturate the canal. Right? It is almost similar. The steps are almost similar. The only difference is that we just fill the canal with calcium hydroxide for a week, and next time when we recall the patient, we just, after drying the canal, we just put MTA, a new relatively newer material, because it sets within 3 hours and it has a good strength. So we just, on the apical third, we just fill it, and then we obturate the canal. Now this is how we have been doing one-step apexification. Here also a number of materials have been tried, but MTA remains the gold standard as far as one-step apexification is concerned. This is one of the cases done with one-step apexification, where we just introduced MTA at the cervical thread, and then the tooth was obturated. Again, if you will appreciate, if you see, there is no root thickening, root dentin thickening, there is no length increase. The only thing which we have done, we have provided a strong apical plug, and then we obturated the canal. MTA has only one good advantage, that it attracts some plastic cells, and as a result, in due course of time, you find little lengthening of the root occurs because the cementum gets deposited on the apical portion. But the problem is, if at all you have to remove that MTA, it is extremely difficult. Now another approach, if the patient comes to you with a sinus formation, you are trying non-surgical approaches and it's not getting success. Now patient pain is not going, sinus is not healing, then what you'll do? You'll go for the surgical approach. But in pediatric dentistry, now surgical approach, you all know, Vishal has just discussed, he has seen episectomy, but I am sure that many of you have not seen episectomy in the young permanent growth. When you gain the access and you try to locate the apical portion, you will find, those who have done, they know it, that the root dentine or the root portion is so fragile that even if you touch it with the curette, no, it will shatter. Right? So making the retrograde filling and packing it with the material itself is a difficult task. And when you make that cavity, you are further reducing the root length. Right? In pediatric dentistry, the moment you say कि छोटा सा operation करना पड़ेगा, it is a difficult task. The patient goes into panicky, parents go into panicky, and they don't want to get the treatment done. And then they start searching some other dentist who says, okay, non-surgical भी करके देख लेते हैं. So this is one major drawback. Root dentine is very thin, very difficult to make a retro cavity, and then the filling. And then, of course, yes, obturated full coverage restoration is not a very good option, but we have been doing it because we didn't have any other option. What to do now? Either you extract the tooth, and most of the time in pediatric dentistry, patients don't want to get the teeth extracted. They want some or the other kind of treatment to be done. So in either approaches, what we have seen, what we have been practicing, what we have seen, the tooth remains non-vital, shorter roots, no root length increases, thin dentinal wall means the tooth is weak, already weak. Apical barrier, in apexification, the literature says that even if the apical barrier is formed, it is not hard structure, it is a cheesy consistency structure and it has micro porosity in it. So the need for obturation is already there. If you leave it, again you will find the little infection. So you have to do it, and then again full coverage restoration of crown you have to get. Now it is something like this. जब तक पुरानी थी हमें बड़ी अच्छी लगती है, the moment we find a new one, पुरानी में बड़ी कमियां दिखने लगती हैं. So this is exactly what we have been doing in the past, and now we found something new. So we started designing the older one. Then we start thinking, was it our goal to restore teeth in such a way? Definitely not. So what should be our aim? Our aim is to provide the treatment in which diseased and necrotic tissues are removed and replaced by healthy tissue, and if possible it can be revitalized. This should be our aim. So there has been a radical shift in the thinking process and in the treatment protocols. We call it as biological solution to biological problems, and in other words, we call it as regenerative endodontics. Regenerative endodontics or regenerative dentistry is nothing but the biologically based procedures designed to replace damaged structures, including polydentin complex. And this regenerative endodontics or dentistry is based on the principles of interplay of three main factors. The stem cells, we all know, the undifferentiated cells capable of self-renewal, then a framework on which these stem cells can be grown and organized, and then the process of organization can be enhanced with the help of certain bioactive molecules. They are known as the growth factors. Now, in regenerative endodontics, we have two approaches right now. One which is known as tissue engineering technology. The other is the revascularization. Now, tissue engineering technology utilizes the highest level of laboratory work, where we grow the stem cells and then implant into the disinfected pulp canal space. While in revascularization, we utilize the stem cells which are present in the periapical area. We just brought these cells into the disinfected root canal and we try to revitalize it. Tissue engineering is nothing but an interdisciplinary field of science and the bioscience, engineering and the bioscience, which is meant to restore the lost tissue structures. These are the three components of the tissue engineering technology. Stem cells are undifferentiated cells. They continuously divide, means they have a self-renewal capability. Scaffold is the platform or the framework on which these stem cells can be grown, and the growth factors are the proteins, the bioactive proteins. Now, stem cells are capable of both self-renewal and multinucleus differentiation, and then they divide to form one daughter stem cell and another one is the progenitor cell, which can be differentiated into different type of tissues. Now they can be isolated from the blastocyst stage, that is the day 5 of the after the fertilization, but extraction or isolation is all legally it is not permissible. Ethically also it is not permissible, though they have a very good plasticity. They can be changed into any type of cells or tissue or organ. So what is the option? Option is to isolate the postnatal cells. They are present in the different body parts, including the dental pulp, and they can be used for regrowing or regenerating the pulp dentin complex. They can be pluripotent also, means a single cell can develop into different type of organs or tissues. The pluripotent, they can be converted into different derms, mesoderm, endoderm or ectoderms, or the multipotent. They are partially differentiated, but still they have a capability to differentiate into almost same type of tissue. Like tooth tissue, they can form the dentine, they can form from the pulp, they can form the cementum as well. So for endodontic regeneration, we have the autologous, means from the same individual. We can take out or isolate the cells from different parts of the same individual, and they can be used for the endodontic regeneration. Now these are certain sources where you have stem cells from the third molar, stem cells from the exfoliated primary teeth, then you have stem cells which are present in the apical area or periapical area, and stem cells from the periodontium. Other types of stem cells are also there, but till date we have been able to isolate only these 4 types, which can be isolated and used for the endodontic regeneration. Now, which one is the best? Again the question. So, all the 4 can be used, but if you are using the exfoliated tooth, the stem cells from the exfoliated tooth, it is better if you take the primary canine, stem cells from the primary canine, and of course stem cells which are present in the periapical area, they have a primary source of odontoblast and they are responsible for the rodent formation. Now the question arises, now once we know the sources, we can always take out these stem cells and directly we can inject into the pulp space which is disinfected or sterile. But we can't do it right now, because the moment you inject it into the pulp space, number one, they are not going to survive for long until they receive the nutritional supply from the bloodstream, and number two, because they are partially differentiated from the periapical area, they may migrate into different area and they may produce apparent calcification problem. So that is why the solution is you use some platform or the framework on which they can be seeded. So this is the second component, which is known as scaffold. Now this provides the framework for the growth, differentiation and organization. Now different types of scaffolds, both natural and artificial or the synthetic, are available, right from the collagen to the fibrin to polylactic and polyglycolic acid. But whatever scaffold you use, you have to keep in mind that the scaffold possess certain properties, and the most important property is the biodegradable. Means they must not leave any residue. They should be replaced by the regenerative tissues, and then they should be able to provide the nutrient and take out the waste from that particular framework. So now you have stem cells and you have a platform on which you can grow these stem cells. But see, the differentiation and multiplication is little slower if you directly put it on the framework and try to grow. So to fasten the process and to regularize the differentiation, we need certain bioactive molecules, the third component of tissue engineering, and they are known as growth factors. Now these growth factors are the soluble proteins and the signaling molecules for the cell division, differentiation and organization. Now we have a number of growth factors, but for our endodontic regeneration, the 2 growth factors are most important: the bone morphogenic protein and transforming growth factor beta. Because transforming growth factor beta is the signaling molecule for the odontoblastic differentiation, and it stimulates the dentin matrix formation or secretion. While bone morphogenic protein, they stimulate differentiation of these stem cells into the odontoblast. So these, and one more important thing for the students and postgraduates, this transforming growth factor beta is the only growth factor which is present in the dentine. So in short, the tissue engineering process is isolating the stem cells, growing and multiplying onto the framework, that is the scaffold, in the presence of bioactive molecules, and then once it is formed, it is implanted into the sterile pulp space, and then we expect some kind of regeneration. The second approach is the revascularization. Now, revascularization is nothing but regaining the blood flow within the necrosed pulp chamber. And the rationale behind is, if the bleeding is established in the disinfected root canal, the formation of the blood clot yields a matrix that traps cells capable of initiating new tissue formation. Now, this revascularization is different from that of apexification, because in apexification, even if you have performed apexification, then the tooth will remain non-vital, it will be weak, and then it will have the barrier, apical barrier, which is again not very strong, it is porous. While in apexogenesis, the tooth is vital, but after you have achieved the tooth dentine formation, you have to go for the obturation of that particular tooth. So the revascularization, which is being now used by many postgraduates and clinicians, it is quite simple procedure, does not require any extra equipment or the laboratory procedure. The only thing you have to achieve ultimate asepsis or disinfection of the canal. Various theories have been put forth how to know how revascularization process works, but I would like to show you this landmark study by Gronthals in 2000 and then 2002, which says that stem cells are present in the apical papilla or the bone marrow. Instrumentation beyond the confines of the root canal to induce bleeding can also transplant mesenchymal cells from the bone to the canal lumen. Now, in short, the stem cells which are present in the periapical area, they can be brought along with the blood to the pulp canal space, and then they are responsible for the regeneration or revascularization of the pulp canal space. Now, American Association of Pedodontics and American Association of Pediatric Dentistry both came together to release a guideline or protocol for the procedure of revascularization. First and foremost is the case selection, and which says in case selection you have to see the tooth must have adequate tooth structure. Means the tooth requiring post and core is not a good candidate for revascularization. Then of course you have to take the informed consent from the patient that he should be ready for multiple sitting procedure, number one, and number two, if by any means this procedure fails, then he should be ready for the conventional therapy of apexification. Now, first appointment, you have to isolate the tooth. The other day I was listening to Dr. Grover. He said that one very good way of making the cavity less of microorganisms is the rinsing, chlorhexidine rinsing for 2 minutes. So this is again applies here, that patient should be asked to rinse with chlorhexidine, 2% chlorhexidine, and then under strict isolation with rubber dam, the procedure should be started. And then once you have gained the access, the minimal instrumentation should be done. Means no biomechanical preparation is recommended, only you have to create this space so that you can put some antibiotic into it. Why we don't biomechanically prepare? Number one, we presume that the moment you start biomechanically preparing the tooth, you are going to cut the dentine. And we all know that the dentine has one of the important growth factors, that is the transforming growth factors beta. So the more you cut the dentine, you are going to lose that particular growth factor. So the chances of revascularization can be reduced. So that is why we do not biomechanically prepare the tooth. We just create this space so that just we can put the antibiotic. And then, as far as possible, chlorhexidine should not be used as irrigant solution, just because chlorhexidine has been proven to be extremely cytotoxic for the stem cells. Then, for disinfection, we use typical antibiotic paste. I think you all know. It's a 1:1:1 weight by weight. Ciprofloxacin, metronidazole, and minocycline, and then just to make the concentration of 20 milligram per ml, and then it is just put into the canal, and then the canal is sealed, and the patient should be asked to report back after 3 to 4 weeks. And in the second appointment, if patient doesn't have any problem, if patient is asymptomatic, then we further move. Otherwise, the same procedure is to be repeated. Then in second sitting, you just again isolate the tooth and then give some local anesthetic, because we are going to pierce the peripheral area in this sitting. So give local anesthetic but without any vasoconstrictor, because we need bleeding, right? And then after that, flushing the antibiotic, we just irrigate it with the 17% EDTA, and the purpose of irrigating with 17% EDTA is to make the tendinal tubules open for the release of transforming growth factor. Then, with the help of a sterile file, go beyond 3 to 4 mm just to induce the bleeding, and wait for the blood to come into the pulp space which you have created, and until the CEJ, and then with the wet cotton we just try to stop the bleeding, and once the clot is formed, you seal with the NTA, and the tooth should be sealed. Now this is how we try to revascularize the tooth. Now how do we come to know whether our procedure of revascularization is working? So radiographically, the resolution of the periapical radiolucency is 1. Second, you have to see whether the thickness of the dentine is increasing or not. Now that is why we recommend that whenever you take a radiograph, instead of the conventional radiography, take a digital radiograph, preferably with RVG, so that you can just measure the thickness of the dentine, root dentine also. So you must remember that root dentine is going to be increased first, then the length. This is again important criteria, and then you have to see for the apical closure as well. This is one of the cases done for the revascularization, and you can appreciate in the post-op that along with the root dentine, you will find the root length is also increased. Along with the thickness of the root dentine, you will find the root length also gets increased. Another case, it was done by Dr. Naseem Shah, and he reported in Journal of Periodontics, in which lateral incisor had very huge pulp, and it was necropulp space, and it was necrosed, and 42 months wonderful results came. Now clinical criteria is the patient should be asymptomatic. See, the books say that okay, it should respond normally to the electric pulp testing for sensibility test and for blood flow, but see, we don't have enough equipment. Now electric pulp testing doesn't work in such cases just because we have already sealed the crown portion with the MTA and the composites. But the clinical criteria is if patient is asymptomatic, and radiographically it shows the root lengthening is taking place, root thickening is taking place, we presume that okay, it's working. So advantages of revascularization is, number 1, it is only 2 visits. You do not require further obturation, you do not require full coverage restoration for that. It is cost effective because no extra cost for the obturation and full coverage restoration is incurred in this. Obturation, again as I told you, not required. The important thing which we achieve, which is if we compare with the apexification, is that we are going to achieve the root length and root thickness. As a result, the tooth strength is increased. Now, after listening all these things, have we been able to align the Dept structure? We have achieved the blood flow, no doubt about it, because the root thickness and dentine has increased. But what was our aim? Why we considered this regenerative procedure better compared to the apexification procedure? Because we wanted 3 things. Number 1 was to regenerate the new pulpal tissue. It is questionable. We have not been able, though blood flow was achieved, but pulp was regenerated or not, we don't know. We have reduced the time, yes, and then we have reduced the brittleness or the weakening of the tooth, because the calcium hydroxide, as you all know, it is hygroscopic in nature. It further draws water from the dentin. So that thing also is avoided when you are using the revascularization. But whether you have been able to generate the pulp tissue, it is a questionable process, just because the tissue should be able to perform the functions of the pulp. And one of the important functions of the pulp to produce the tertiary dentin or the reactionary dentin. Can we be able to achieve this? Is a questionable process. So histologically, we have not been able to do it. Now, you cannot examine the tooth histologically until the tooth is again, taken out or extracted and then examined histologically. But there has been a landmark study done by Anderson, and it was published in Dental Traumatology, who examined a number of teeth in which the regeneration was tried, and he came out with the conclusion that there are 4 types of tissue which are expected or which have been found histologically. Now, how they examined all these teeth, we don't know, but probably some of them were extracted, some of them were, because of the trauma, they were avulsed and then they were histologically examined. But after examining histologically, they found these 4 types of tissue which were present in the root canal space. First, he said the revascularization of the pulp with accelerated dentin leading to pulp canal obliteration. He said this particular type of tissue was near to the pulp, but because it has enhanced activity, so later on it resulted in the obliteration of the canal. But rest 3, ingrowth of cementum and periodontal ligament, ingrowth of the cementum, periodontal ligament and bone, and then ingrowth of the bone and bone marrow. All these things are not the pulp tissues. They are pulp-like tissues. They are not pulp. Since they are not pulp, they cannot be considered as a pulp revascularization or regeneration. So now, where do we stand now? Though clinically and radiographically we have been able to achieve something which was better than the apexification, but we have not been able to regenerate or revascularize the pulp. So, in the end, there are few points to remember. That 30% injuries which occur in the permanent dentition is in the young permanent teeth. The apical pulp plug which is formed after the apexification is not that hard. It is porous in consistency, porous and soft in consistency. The obturation, you have to do it after apexification just because apical plug is not continuous. Vertical and lateral condensation techniques are not recommended in apexificated teeth. Rather, a thermoplasticized gutta-percha obturation technique is recommended in this. And then, if at all you have to remove NDA, it is difficult to remove. Stem cells in the third molar and in the exfoliated primary teeth. Reportedly, they produce tissue very similar to pulp-dentin complex. Then, if you need post-and-core preparation, the regeneration or revascularization is not a correct choice for you. Minimum canal instrumentation, as I told you, that the moment we start preparing the canal, we are going to lose some of the growth factors, and that is why it is not recommended. And chlorhexidine has been rated as extremely cytotoxic to the stem cells, and that is why, as far as possible, it should not be used as irrigating solution. So these are certain points. Now, minocycline literature widely says that it causes discoloration, but there is another hidden fact that it causes postural hypotension as well. So the moment you try triple antibiotic paste utilizing minocycline, be cautious. The patient might feel giddiness after he is off to your clinic. So you must inform the patient regarding this, and that is why cefaclor has been now used as an alternative to minocycline. Now you have to tell to your patient that treatment cannot be assured. It is always a probability, because patient will definitely demand when you try for something new, like revascularization. The patient will say, what is the guarantee? Then you have to tell to the patient, there is no guarantee, we are trying our very best. If it fails, then we have to switch back to our apexification procedure. So, just in conclusion, with the introduction of regenerative dentistry, it seems possible to induce biological replacement of the dental tissues, including dental complex. But until we have more exhaustive studies with sufficient number of literature available to us, we cannot recommend it to be used routinely in our day-to-day practice. So I urge all postgraduates particularly to try revascularization and then record this particular case and then come up with a conclusive study before we finally recommend this regeneration process. Thank you very much. Once again, with this note that arise away.